Today, I'm going to try to describe the factors or designs for intravenous needleless connectors that have been associated with the lowest risk of infection. I consult for a large number of companies, and today we're going to discuss, first of all, the pathophysiology of how catheter-related infections occur and the role of needleless connectors. Then discuss some of the current guideline recommendations, and then focus on prioritizing needleless IV system features that have been associated with the lowest risk of infection. If we start by looking at catheter-related infections, in particular bloodstream infections, as shown by this study by Krenish and Mackey, the risk of infection varies by the type of catheter that's being used. From the lowest risk with peripheral intravenous catheters, as shown here, at 0.6 per 1,000 catheter days, to higher rates, such as in the range of 2 to 3 with arterial or short-term non-tunneled CVCs, to 5.5 for pulmonary artery catheters. So what we see with this type of study is that the risk of infection varies by the type of catheter that is being used, and is a good example of why you should be comparing your rate over time within your own institution and not comparing it to either what the Centers for Disease Control and Prevention surveillance system has or another hospital where you don't know what kind of catheters are being used. If we look at all patients in the hospital that have an intravascular catheter, about 10 to 40% of those patients will die. But many of those deaths are secondary to underlying disease or severity of illness. And when we control for those factors, about 2 to 15% of patients die directly as a result of the intravascular device. We know that these infections prolong hospitalization for as much as 5 to 20 days, and these infections are very costly to our healthcare systems, with estimates ranging from $34,000 to over $56,000 per episode. There are a wide variety of factors that influence the infection risk associated with an intravascular catheter. First is, what type of patient is it? Is it a medical or surgical patient, a neonate, a patient with immunocompromise? What is the type of catheter being used, as we saw previously? How many of those catheters are in place? Where in the hospital the catheter is inserted? Is it inserted in the emergency department or in the intensive care unit? The site and the patient that the catheter is inserted, and the duration of catheterization, in addition to whether the catheter is impregnated and how many lumens the catheter has. In addition, the features of the needleless connector and the protocols used with that connector influence infection risk. What is infused through the catheter, particularly blood, parenteral nutrition, lipid emulsion, increase the risk of biofilm development and increase the risk of infection. What is the level of training of the individuals that insert the catheter? Do you have an IV or PIC team, or do many physicians or many nurses insert the catheters? And what is your method for documenting the bloodstream infection? Do you do a culture from a lumen of the catheter and a peripheral stick? Just do cultures of the lumen of the catheter, or just do peripheral sticks? And then the interpretation and application of either CDC definitions or your own country's definitions and protocols, as well as other infection control practices. So as you can see, a wide variety of factors influence the risk of a catheter-related infection. And no study published to date has controlled for all of these factors. It is critically important to understand the pathogenic mechanism for how these infections occur. As depicted on this slide on the left-hand side, we have extraluminal, or the outside of the catheter, colonization. Depicted here is a catheter being inserted into the skin. The little red dots are bacteria that are on the skin, and those bacteria attach to the outside of the catheter. They then produce an exopolysaccharide, or some people call it a biofilm, that can protect them from the patient's immune system, as well as from antibiotics that may be in the blood. They then can reproduce and ultimately can cause infection. And very elegant studies have documented that this extraluminal colonization is the major source for infection early after catheterization. Early being ill-defined, but usually less than a week. When you think about it, the insertion bundles that have been recommended focus primarily on this. Next, after the catheter is inserted, we manipulate that catheter. We inject medications. We withdraw blood specimens for testing through that catheter, the needleless connector, or the stopcock. And through that manipulation, we inadvertently contaminate the intraluminal surface of that catheter or connector. And it goes through the same process as bacteria did on the outside of the catheter. They stick to the catheter, produce an exopolysaccharide or biofilm, and then can reproduce and cause infection. And this intraluminal colonization is thought to be the major source of infection late, usually after 7 days. And if you think about it, the maintenance bundles that have been recommended are primarily attacking this. And needleless connectors really span both extraluminal and intraluminal colonization. The next thing that's important is to understand where did the bacteria come from that cause these infections to occur. About a third of the time, we don't know. In Western Europe and in North America, this contaminated infusate has been virtually eliminated and accounts for less than 1% of the infections. That contaminated infusate could be intrinsic contamination during manufacture or extrinsic contamination during manipulation in the hospital. But we now have virtually eliminated intrinsic contamination as well as extrinsic contamination by admixing medications and infusates in the pharmacy or using unit dose medications. So we really don't have to worry much about this. Next is contamination of the hub or the connector, and that is thought to occur in about 12 to 20% of the time. And the source of those organisms are either the patient's own skin organisms or the organisms on our hands as healthcare workers. The most important source, accounting for nearly 60% of infections, are the skin organisms, the patient's own skin organisms or the healthcare workers' skin organisms. If we look specifically at needleless connectors, we've seen an evolution of the type of connector over time. Initially starting with split septum, negative pressure split septum connectors, which produce negative pressure during either insertion or removal. That was followed by lure-activated connectors that again were negative pressure. Then we had lure-activated mechanical valve connectors that produce positive pressure on activation or disconnect, with the potential benefit of those reducing the risk of occlusion. And then lastly, we've seen the introduction of what's called neutral needleless connectors. It's important to realize that the infection control practices in particular clamping and disinfection of those connectors, differs for those that produce negative pressure versus those that produce positive pressure. These devices are easy to use, but there are some inherent risks due to design. For example, the clinician may not disinfect the surface of the connector. If they don't do that well, then the potential for introduction of organisms into the fluid path exists. Next is ensuring that the line is flushed correctly or per protocol. And there's confusion oftentimes by clinicians in understanding, do they clamp and then disinfect, or do they disinfect and then clamp? And then do they replace the device correctly according to protocol? And the frequency of these user errors is really unknown. Questions have arose about how do these connectors become contaminated, or even do they become contaminated? And this is a study by Bob Sharitz and Toby Karchmer from Wake Forest University in the United States, where they did quantitative cultures through the line and the connectors on all of their intensive care unit patients in 7 different intensive care units. They obtained 226 discards, as they were called, from 83 patients. They sent these to the laboratory to be cultured and found that 39 of that 226, or 17% of them, were culture positive. They had 7 different ICUs. The lowest rate in one ICU was 8%, but the highest rate in another ICU was 50%. That's 50% of the blood cultures obtained through the line and the connector growing an organism. The colony-forming units, or the magnitude of growth, was relatively small, and there was wide diversity in terms of pathogens. The majority were coagulase-negative staphylococci, but they recovered 5 yeast, 2 Staph aureus, 2 Serratia, 2 Enterococci, and 1 each of Sternotrophomonas multifilia and Acinetobacter. So even though the largest number were organisms commonly associated with skin contamination, there were a wide variety of both gram-positive and gram-negative organisms that most clinicians would consider true pathogens. They then went back and asked nursing personnel in those ICUs how frequently they manipulated that connector without disinfecting it. And 31% of the time, the nurses acknowledged doing so. So if we look at characteristics of needleless connectors, there's 2 major areas to keep in mind. One is access to the fluid path. Is it done through a needle or a blunt cannula, or is it through lure-activated access? And how well does it seal to prevent bacterial contamination? Second is the internal design. Is it a simple design, or is it complex? And one of the unintended design consequences of complex internal mechanisms, some of which have been developed to produce positive pressure, for example, is that it causes space within the connector, but outside the fluid path. And when the fluid and contamination leak into this space, it then can lead to contamination of the lure and ultimately enter the fluid path. There are a number of different characteristics that can influence the infection risk. Obviously, disinfection of the external surface is critically important. fluid displacement of negative, positive, or neutral, or some people call less negative, was initially thought to be a major factor, but now is thought more to be an indirect factor, and the mechanism of how the negative or positive or neutral pressure is produced in terms of the internal mechanism is probably more important. And again, is that internal mechanism simple or complex? And are there moving parts? Access to the fluid path, again, either blunt cannula or luer access. And then the internal design. And is the fluid path a straight fluid path, or is it a flow around fluid path? The priming volume, or the amount of fluid required to remove the air, and the dead space, are spaces that are inside the housing where fluid can leak when it's flushed, although the original design was that the fluid would not be able to escape to those areas. Access type is primarily now luer-activated access. A direct fluid path is critical because it reduces the surface area where biofilm can develop, and it enhances the likelihood that flushing is done correctly. Visibility in itself is really not that important. The visibility, whether it's opaque or clear, is directly related to the ease of complete flushing. Because we know if we don't flush those connectors well, that then blood, total parenteral nutrition, lipid emulsion, glucose-containing solutions can remain in the connector, and biofilm can develop, and or organisms then have nutrients to grow. And that connector external surface is the most important. Is it solid? Is it sealed? Is it flat? Or is it indented, angled post, or other irregular surface? Some of the mechanical valves have required end caps to keep them sterile, and getting compliance with putting those caps on is very difficult. And we know that the more intricate the access surface, the more difficulty it is for clinicians to adequately disinfect them. If we look, there's a wide variety now of luer-activated mechanical valve needleless connectors, whether they be positive, negative, or neutral pressure. Some of them are sealed well, as shown here on the left, and others are not, as you can see there with a gap around the plunger, or here where you have a very complicated external surface where it is difficult to get your disinfectant down into those areas. If you look at the needleless connector, you want one that has a relatively flat surface rather than an area of indentation or angled post. As shown here, this surface here, which almost looks like a tennis ball, but it's very easy to disinfect, whereas that is very difficult to disinfect, and that with the gap is virtually impossible to adequately disinfect. So when we're thinking about visibility, it really isn't the visibility itself that's so important. It's how that translates into the ability to adequately flush the catheter. We have a number of needleless connectors that are clear. There is better visibility, but the internal design is much more complicated and therefore may be much more difficult to disinfect even though they're clear. So keeping in mind simple versus complex. We have a simple design here with a very straight fluid path. Here we see a more complicated device with a tortuous fluid path, and then a very complicated one here with a wraparound or flow around fluid path. And as you look at these designs, you can see that the more complicated and indirect the fluid path, it somewhat translates to the more complicated internal design, and you have a lot greater surface area in these complex connectors for biofilm to develop than you do in a simple design where fluid has a very direct path. It's also easier to flush the device. So we have a group of catheters that have what's called reverse split septum. So instead of having the septum up here and activated through either a blunt cannula or lower access, it's now the reverse. But these provide a very direct fluid path with minimal area that fluid contacts, therefore reducing the risk of biofilm development or contamination. Another thing to keep in mind is this fluid path, oftentimes with the connector, is of silicone, but it may be also of stainless steel, which reduces the risk of biofilm development. And that direct fluid path minimizes the surface area that the fluid is having contact with, and as a result, minimizes the risk that biofilm will develop. In contrast, connectors that have an indirect or flow-around fluid path or non-direct fluid path, such as these, have a much greater surface area that the fluid contacts, and oftentimes a much more complicated internal mechanism. As I mentioned before, initially, when there were a number of outbreaks associated with a different variety of mechanical valve needleless connectors, the belief was that fluid displacement was the issue, that the majority of the outbreaks were associated with positive pressure needleless connectors. In the United States, that led to the Food and Drug Administration actually issuing what's called a 522, which required the manufacturers of those connectors to do studies to document that the risk of infection associated with their positive pressure needleless connector was equal to or less than that associated with neutral or negative pressure connectors. That led to a number of companies withdrawing their connector from the marketplace, and 2 of the companies to do studies to try to document that the risk was less. But it led to a further understanding that the fluid displacement, such as negative displacement, as you can see here, when you disconnect, you get blood flow back into the either catheter or connector. With neutral displacement, with disconnect or connect, you get no movement either out or in. And with positive fluid displacement, you initially get positive flow with disconnection, and it reduces the risk of reverse flow or negative flow into the connector or the catheter. Now we know, despite whatever direction the fluid is moving, whether it be negative, neutral, or positive, that it's not the movement of the fluid that is leading to infection risk. It's rather the design of the connector, in particular, the very complicated designs with the initial positive pressure connectors that led to increased risk. So we know that with these connectors now, it's preferable to use a connector that does not require a clamping sequence. On the other hand, if you're going to use either a negative or a positive pressure connector, it is best if you only use one type in your hospital rather than a mixture. I've been at academic centers in the United States where they were using a negative pressure and a positive pressure connector, and I can tell you that both the physicians and the nurses in the intensive care units really didn't understand that the clamping disinfection sequence was the opposite between those two types of connectors. So they were probably getting it right at best 50% of the time. There's been a number of studies now on the disinfection of these devices. This is one by Menahy and Mackey, where they took 3 different lure-activated mechanical valve needleless connectors, and they inoculated them 8 colony-forming units of Enterococcus faecalis. They then let them sit and dry for 24 hours, and then they took a syringe with broth. With the first group of connectors, they did no disinfection, connected, put the broth through and cultured it. With the second group of connectors, they did what they described as 3 to 5 seconds of vigorous wipe with 70% alcohol, and then attached the syringe and shot the broth through and then cultured it. And with the third group of connectors, they used a chlorhexidine impregnated cap, which did not even exist in the marketplace at the time. This shows their results. Not surprisingly, if you do no disinfection, 100% of the cultures grew, with as many as 28,000 colony-forming units. Surprisingly, if you did 3 to 5 seconds of vigorous wipe, and think what goes on in your facilities, I very commonly see the needleless connector, and the nurse or physician takes an alcohol swab and goes like that and then connects. Maybe at most 1 second. Certainly not 3 to 5 seconds of vigorous wipe. And with 3 to 5 seconds of vigorous wipe, still 67% of the connectors grew organisms, with as high as 25,000 colony-forming units. With the chlorhexidine impregnated cap, only 1 was positive and fairly low number of colony-forming units. So, at least with these specific connectors, the data would suggest that a 3 to 5 second wipe, even if done vigorously, with 70% alcohol, is insufficient. Subsequently, Kaler and colleagues published their results in JAVA in 2007. In this study, they took a larger number of mechanical valve needleless connectors from 3 different companies. They used a lower inoculum of 10 to the 5 colony-forming units per ml. So their final inoculum after drying was probably 10 to the 2 or 10 to the 3. So this may be clinically a little bit more relevant. And they took a wider variety of organisms: Staph epidermidis, Staph aureus, Pseudomonas aeruginosa, and Candida albicans. They then did what they described as 15 seconds of scrub of the hub, as if you're making orange juice, for 15 seconds, with either 70% alcohol or chlorhexidine with alcohol. And when they did that, either one of those were sufficient. No organisms grew. I think these 2 studies, as well as one by Mark Rupp and colleagues, show that we need to have connector-specific recommendations for disinfection, because some are very simple in design, flat surface, no gap around the plunger, and are relatively easy to disinfect, and others are much more complicated and therefore need more time to adequately disinfect them. This is just a visual illustration of this fact. So this is putting glow germ on a connector and then scrubbing it with alcohol and then attaching a syringe. And you can see on the internal surface of that syringe the glow germ. And so if you were injecting fluid into this patient, that contamination would enter the fluid path and potentially lead to infection in your patient. This is a picture of the external surface of a needleless connector, showing biofilm development, and as shown here, biofilm with gram-positive cocci. This is from the inner surface of a connector, and again you see biofilm development with many gram-positive cocci. As mentioned before, the internal mechanism can obscure the fluid path. And in doing so, not only do you have a tortuous fluid path, but it becomes impossible to know whether this connector has been adequately flushed or not. So it's not solely visibility, it's also internal design. So what are the latest recommendations on the use of needleless connectors? We have 3 different groups that have somewhat recently made recommendations. The first was the CDC HICPAC IV guideline in November of 2011. And that guideline stated that when needleless systems are used, a split septum valve may be preferred over some mechanical valve due to increased risk of infection with some of the mechanical valves. It was a category 2 recommendation. And when you look specifically at that recommendation and the discussion afterwards, they commented upon the fact that there had been a number of outbreaks and that external surface simplicity and ease of disinfection and internal mechanisms were important. The Society of Healthcare Epidemiology of America, or SHEA, and the Association for Professionals in Infection Control and Epidemiology, or APIC, and a number of other organizations have put out their strategies to prevent central line associated bloodstream infections, first in 2008, and now an update in November of 2014. And they have made now the routine use of needleless connectors as a CLABSI prevention strategy before assessment of risks, benefits, and education regarding proper use as an unresolved issue. They point out that multiple devices are currently available, but the optimal design for preventing infections is unresolved. And then they point out that the original purpose of these needleless connectors was for prevention of healthcare worker needle stick injuries and not prevention of infection in patients. And again, they comment on a number of the outbreaks that have occurred and point out the importance of the internal mechanism, the difficulty sterilizing gaps in the valves, the intricate access surface that are difficult to disinfect, and again, complicated, multiple moving parts. Your guideline here in France, published in December of 2013, says that if needleless connector is used, a valve system with split septum is preferred to certain mechanical valve systems with regard to the infectious risk associated with these devices. And to choose a connector with an easily disinfectable membrane, so a flat membrane, transparent to allow evaluation of flushing, and resistant to multiple injections. And that when a needleless connector is used, it is necessary to do an efficient disinfecting procedure with an alcohol antiseptic before any use, and essential to flush the internal pathway after any use. So it highlights again 2 of the most important features of needless connectors. So it's important to remember these two critical features. First is the access surface. Is it solid and is it sealed? Can it be effectively disinfected? There are no crevices, slits, holes, or gaps that can trap or allow contaminants to penetrate that connector. And then secondly, is the internal design simple? The entire interior of the connector is active space where 100% of fluid can be exchanged. So it's being flushed each time it's used. And there are no internal cannula or complex mechanisms creating empty space or increased area for biofilm development that's outside the fluid pathway, where contamination can occur, become trapped, and you really can't flush it. And yet it can then re-enter the fluid path. So the desirable features that you should look for in a needless connector are first to have a flat, smooth, easy to disinfect external surface. To have no opening or gap around the sealed septum. To have the least complex internal mechanism. To have a straight fluid path rather than an indirect or flow around fluid path. To minimize the dead space. To have no required clamping sequence. To have no blood reflux. And be able to flush with saline rather than heparin to reduce the risk for heparin-induced thrombocytopenia. So in conclusion, there have been several generations now of needless connectors with different designs. And more studies are being published that are conclusive in associating specific and different needless connector designs with increased CLABSI risk. Needless connectors are an integral part of the CLABSI prevention, insertion, and maintenance bundles and should get the same amount of attention as maximum barrier precautions, use of chlorhexidine with alcohol for skin prep, because when you think about it, the needless connector is with that connector for a long period of time, whereas the insertion bundle that we focus so much attention on actually accounts for oftentimes less than 1% of the time the catheter is in place. That's not to say that insertion bundles are not important, but maintenance bundles and focusing on the needless connector is as or more important. That advanced Luer-activated needless connectors with a reverse split septum design feature possess more in common with the early designs that were not associated with increased CLABSI risk.